All right, welcome back. This is the final part of our series on BPV. We've talked about what it is and how to diagnose it, but now we get to the really good stuff, the most rewarding part, actually, which is turning that diagnosis into a real cure right there in the ED. And this quote, this really hits the nail on the head. Our goal today isn't just about handing out some medication to make the patient feel a bit better for a few hours. No way. It's about giving you the actual playbook to fix the root cause of the problem, right then and there. Okay, so let's get right into it. The solution here, well, it's not a pill. The cure for BPV is totally mechanical. We're going to use gravity as our best friend with these things called particle repositioning maneuvers. And we have to start with the most common one, the usual suspect, posterior canal BPV. I mean, it's the cause in up to 90% of cases, right? And here it is. Our number one tool for that posterior canal BPV is the Epley maneuver, which you can see beautifully illustrated here. It's just a really smart 4-step sequence that's designed to gently guide those little rogue crystals, the otoconia, out of the canal and back home where they're supposed to be. So here are the steps. And what's super important to notice is the timing. Each of these 30 to 60-second holds isn't just a random number, it's totally deliberate. You have to give those little crystals enough time to settle with gravity. Think of it like guiding a tiny marble through a maze. You have to pause at each turn to let it roll to the right spot, all the way until it finally pops out into the utricle. And the results, honestly, they're just fantastic. We're talking an over 80% success rate on the very first try. And why is it so good? Well, because it's a simple mechanical fix for a simple mechanical problem. For most of your patients, this means that horrible, debilitating vertigo is just gone in about 5 minutes. That's a huge win. Okay, so that's the posterior canal. What about the horizontal canal? It's definitely less common, only about 5 to 15% of cases, but you still need to know what to do, and the approach is totally different. This is where the supine roll test becomes our key diagnostic tool, and it's a really important decision point in our treatment plan. So when you do that supine roll test, the one thing you're looking for is the direction of the nystagmus. Is it beating towards the ground? That's geotropic. Or is it beating away from the ground? That's apogeotropic. Just that one observation tells you everything you need to know. It tells you if the crystals are free-floating or if they're stuck. And that one detail, it changes your entire treatment plan. So for that more common geotropic type, the free-floating crystals, we use something called the BBQ roll. And yeah, the name is pretty much what it sounds like. You're literally rolling the patient a full 360 degrees in these 90 degrees steps. It's a really logical sequence that just walks those particles right around the canal and out. And it works really well, about 70 to 80% of the time. All right, so you've done the Epley or the BBQ roll. Your patient is sitting up, maybe saying they feel better, but how do you really know it worked? How do you confirm you've actually fixed the problem? Let's get into that. Because this is the moment of truth, right? This is what lets you confidently send the patient home. It's the step that proves you've provided a cure, not just a temporary patch. So we absolutely have to get this part right. And the answer couldn't be simpler. You have to retest. It's not optional. You look at any management pathway, like this one, and you'll see it plain as day. Right after the maneuver, your very next job is to check if that nystagmus is gone. And how do you retest? You just do the exact same provocative test you used to diagnose it in the first place. The Dix-Hallpike for posterior, the supine roll for horizontal. If you do it again and nothing, no nystagmus, then you can be confident. You did it. You successfully treated the BPPV. Those little crystals are back home. Now, let's talk about symptoms for a second. While you're doing all this mechanical fixing, your patient is probably feeling pretty awful. Really nauseous. So yes, it's totally fine to give them something like ondansetron to help with that. But, and this is a huge but, you have to remember these are just adjuncts. They help with the nausea, but they do not cure the BPPV. They just mask a symptom. Okay, so you've confirmed the fix with a negative retest, the patient's feeling better. What's next? Well, the final piece of the puzzle is what to do with the patient. Let's talk about smart disposition. This flowchart really lays it out perfectly. It's a super clear decision tree. Look, if the vertigo and nystagmus are gone, the path is simple. They can be discharged. But if the symptoms are still there, or if something just seems off or atypical, that path forks. And that's a whole different conversation. So for most of your patients, the ones who are now symptom-free, a safe discharge is all about giving good instructions. You got to tell them, hey, this can come back. Advise them to take it easy with driving for a day or two. And it's a great idea to teach them some home exercises. Even simple things like sleeping with their head propped up for a couple of nights can make a real difference. But, and this is another big one, if you see any of these red flags, everything changes. Your whole approach has to shift. If you see nystagmus that just doesn't fit the BPPV pattern, like if it's pure downbeating or it doesn't get better, or if there are any other weird neurological signs, you have to stop. This isn't simple BPV anymore. This patient needs a specialist referral, and you've got to start thinking about neuroimaging to rule out something more serious. Okay, that was a lot. So let's boil it all down into a quick playbook, something you can keep in the back of your mind for your next shift when that dizzy patient comes in. And this table is basically your cheat sheet. It's the core of the whole strategy. It's all about matching the right move to the right problem. Posterior canal, you use the Epley. Horizontal, it's going to be the BBQ roll or the Gufoni. It's just a systematic way to tackle a very mechanical problem. And with that, we've wrapped up our 3-part series. We've gone from start to finish, right? From just recognizing the dizzy patient to running the right diagnostic tests, and finally, to providing a definitive treatment and making a smart disposition. It's the whole package, a complete clinical pathway to a cure. So I'll leave you with this question to think about. Now that you know you can literally cure BPPV at the bedside, how is that going to change your approach? How will you shift from that feeling of uncertainty to one of real confidence and decisive action? Our hope is that you feel empowered to tackle this incredibly common and incredibly curable condition head-on. Thanks so much for watching. If you want to dive deeper into dizziness, vertigo, or imbalance, or if you're looking for great resources for both you and your patients, please come visit us at our website, AustralianDizzinessClinics.com.